Hello, everyone. I'm just going to share my slides. Okay, so neuroendocrine tumours or NETs. So this is a whistle-stop tour, and this is for specialists. So in a hospital, as a doctor or nurse in various specialities, and gastroenterology, endocrine, oncology, and surgical specialists come across neuroendocrine tumours. So we can also call them neuroendocrine neoplasms or NEN. So it can be quite confusing. Neuroendocrine neoplasms are a more umbrella term, and neuroendocrine tumours are used historically and can shorten them to NETs. So these are three famous people who had NETs and sadly died: Steve Jobs, Aretha Franklin, Irfan Khan, who had all pancreatic NETs, incidentally. And what are they? I mean, they're cancers, but where the cancers arise from, these come from neuroendocrine cells. So these neuroendocrine cells can occur in different parts of the body and do normal physiological functions. So there are neuroendocrine cells that form glands, such as the pituitary, parathyroids, adrenal medulla, and the neuroendocrine cells that normally occur spread throughout tissues, such as the GI tract, pancreas, skin, lung, etc. And these are the cells that give rise to neuroendocrine cancers. Originally called, way back almost 100 years ago, carcinoid, which is the old term, carcinoid, cancer-like. From Orbendorfer, you can see on the left, bottom left. So the neuroendocrine tumours can come from different parts of the body, and they can start in the stomach, pancreas, small intestine, quite commonly, but can arise in different sites, like the lung. And we call these bronchial nets or lung nets, and stomach nets we'll call gastric nets, etc., etc. They are a type of cancer, and on the right-hand side, you can see the incidence of all cancers in the States, and that's the blue line, which is relatively static over the last few decades. The incident nets have increased as awareness has increased, and there's a real increase. And so they are very varied in terms of the survival. So this is a busy slide, but all you've got to remember is that the y-axis is the median overall survival, and it goes up to 400 months there, so that's quite a long time. And these are different types of nets in the top graph here, from pancreas, lung, small bowel, as I mentioned, quite commonly. And the localized disease, people can survive for a very long time. And even in a metastatic section, a distant disease, which is the right of each of the three graphs, you can see that in the small intestine, some people can survive for 7 years or so, where it was sort of 84 months or so. So very varied survival, even with metastatic disease. And because of this, people survive with NETs for a long time, and the prevalence is quite high. So the second most prevalent gastrointestinal cancer. Again, busy slide, but what we've got to take from here is that gastroenteropancreatic nets that come from the gut, can be split into pancreatic or non-pancreatic, which is usually small bowel. And then each of those can be divided into whether they're functioning or non-functioning. So this is whether they produce hormones or not. So functioning pancreatic tumours can produce insulinomas, like Steve Jobs had. But most commonly, they are non-functioning and they don't produce these hormones. And the non-pancreatic small bowel, about 30% of them will be producing hormones, usually serotonin. So the most common, the thing to take from here is most commonly they don't secrete hormones, but a proportion will do. So the small bowel nets, I'll go into a bit of detail, account for almost a quarter of all GI nets. 2/3 are metastatic, so late diagnosis at the time of diagnosis, and a small proportion have this carcinoid syndrome with the flushing, diarrhea, and a very small proportion have carcinoid heart disease. And that carcinoid heart disease gives a poor prognosis. So carcinoid syndrome, which is usually produced by serotonin, produced by the tumor in a metastatic setting. And you get the malar flush here, and actually a dry flush of the face, the upper body, the neck, usually triggered by alcohol or stress, but it's not a wet flush, which can be confused with the menopause. And usually it's diarrhea and flushing, which are part of the syndrome, and a small proportion can get heart disease, as I mentioned, because of scarring or fibrosis of the bowels, usually from the serotonin and other compounds. And this is just to explain, we measure 24-hour urinary 5-HIA, and that's a marker. Sometimes we can use plasma 5-HIA in certain centers, but the tumor produces serotonin, that's 5-HT. It goes into the bloodstream, get metabolized by the kidney, and we measure the 5-HIA, which is the metabolite of serotonin, indicator of how much serotonin has been secreted in carcinoid syndrome. Again, the majority will not produce this. And because serotonin is produced from tryptophan, and tryptophan is normally used to make nicotinic acid, and this is the normal state of affairs with a small amount of 5-HIA being produced, there's an abnormal metabolism of tryptophan in the neuroendocrine cells, and this then means that you can get deficiency of nicotinic acid and pellagra, vitamin B. Fibrosis, as I mentioned, of the heart valves is not metastases. It is just scarring due to the hormones produced by a metastatic neuroendocrine tumor. And it's reduced in prevalence over the years as we've become better at managing NETs, but it's basically halved the survival rate. So it's a very poor prognosis unless you can get valve replacement. When people are diagnosed, they usually have vague symptoms depending on what NET they have, and quite commonly there are misdiagnoses such as IBS or Crohn's. And the presenting symptoms with most midgut or GI NETs are here: abdominal pain, diarrhea, and in the carcinoid syndrome, facial flushing, and some small proportion having weight loss. So it can be vague GI symptoms. The quarter can present as an emergency with obstruction, and 10% may not have, or 11% may not have symptoms. This is data from Wales. Looking at the specialities that make the diagnosis, it's usually the GI specialities: colorectal surgery, general surgery, upper GI surgery, gastro, etc. That's because of these symptoms, which maybe indicate some other common diseases, which you should always think of prior to being aware of NETs. And those are the specialities that should be concentrating on being more aware and diagnosing them. Chromogranin A is something which is talked about a lot, but it's not a very good blood test for diagnosis. Its sensitivity is quite varies between 60 and 90%, but actually there are so many non-specific sort of false positives on the bottom left here with chronic PPI use, and it's not raised in small volume NETs. And so in a diagnostic pathway, it's not terribly useful unless you're sure there is a NET on imaging. And the diagnostic algorithm can be complicated, but this is a publication, but the main thing to take away is the CT scan. Imaging should show up a NET wherever it is. And the tissue diagnosis, encircled, is the key thing to obtain, because that will confirm NET under the microscope. So a classical story is this of a 57-year-old female who had 6 years of intermittent loose stool, some mild abdominal pain, labeled as IBS, had some normal investigations, including colonoscopy, and was referred twice through gastro and surgical clinics for diarrhea. And she was given the usual IBS treatment because people thought she had a normal colonoscopy and negative celiac screen. And she had a stable weight, although had lost a little. She had a normal second colonoscopy because she was referred. And then there was another referral to a surgical specialty who arranged a CT colonoscopy, which revealed this. And hopefully you can see arrowed on the top left is a cicatrizing mass with some stellate appearances. So it's like a mass with some calcification. It's a lymph node metastases with some fibrosis around it. And it's tethering the small bowel. And you can see in the second image there is a liver metastases on the right side. So this person had a normal 5-HIA and a relatively normal chromogranin A. So those weren't particularly helpful, but the imaging was. Patient went on to have a biopsy of the liver, and this showed a neuroendocrine tumor. And the black cells are those that take up a particular stain called Ki67, and which I'll go on to explain. So when you got a pathology report, would have confirmed that it's neuroendocrine neoplasm or neuroendocrine tumor. And then it's how well is it the cells differentiate. And that's the pathologist will tell you how well the cells look like normal neuroendocrine cells, well differentiated, or are they poorly differentiated and they've gone out of control. The Ki67 stain, it is taken up by cells in active mitoses. And you can see on the right-hand side, 6% is what the pathologist came up with of the total net cells that are in active mitoses. And that's important because that tells you how aggressive the net is. And we talk about grade, so low grade, middle grade, high grade, and we use the Ki67 cutoffs to determine how aggressive the tumor is. The majority be low grade, and the differentiation, usually poorly differentiated, are very high grade and very aggressive. And the grade is prognostic. So the bottom left graph shows 3 lines, survival curves. The top line is shallow, meaning patients survive quite a long time, and that's low grade, as opposed to the deeper line, which is the orange line, the bottom, which people are dying quickly, that's high grade. So important to know what the grade is. Somatostatin receptors are present on most nets and neuroendocrine cells. There are different types of somatostatin receptors, and we use them diagnostically and in therapy. So octreotide scan is a molecule, is a scan where a radio-labeled Indian 111 labeled octreotide molecule binds to those somatostatin receptors that we just saw on the surface of the cell. And because of the radioactivity, radionuclide scans or scintigraphy can be undertaken. You can localize where nets are in the body. Now, gallium PET is available in quite a lot of countries, including a number of centres in the UK, and there's much more sensitive than octreotide scan. So you can see at the bottom, very nice pictures, details of uptake of nets in the liver. So gallium PET is the best modality if it's available for low-grade nets. A normal PET scan will pick up the very active, aggressive cancers, so we'll pick up the higher grade nets or the neuroendocrine carcinomas, the more aggressive element. Treatment of lens, I'm going to have to the whistle-top tour through it because it's very complicated, but you can split it into surgery, somatostatin analogs, localized liver-directed therapies, which I won't talk about, molecular targeted treatments and chemotherapy, which our oncologists generally would give, and other systemic treatments. And this is a busy slide, but it just highlights that people can have first line, second line, third line therapy, and at various degrees of different surgeries and different systemic treatments. So it's quite complicated, and you do need an MDT. So this the NET MDTs, usually we have European Net Centre of Excellence in Europe, and this stipulates that there should be a number of different specialists inputting into the care of the patient in a tuber board or MDT meeting. And every specialty and staff member is valuable. So remember those somatostatin receptors. This is the mainstay for therapy in most nets. So this is a somatostatin analog in a circle here, and it's binding to somatostatin receptors on the neuroendocrine cell. And it can reduce the amount of hormones produced, so therefore help carcinoid syndrome, flushing, and diarrhea. And that's been used for many decades. But it was only until recent times where it was also known to reduce the growth rate. And so in the last 15 years or so, they've been used as anti-tumor agents, even if it is a non-functioning net, so even if it's not producing hormones. And we have lanreotide autogel and octreotide LAR, which I just mentioned earlier. We can also use a very new drug, which is available in some countries. Telotrestat is a tablet which inhibits the serotonin production. So if you remember, look at the bottom right, if you remember that tryptophan metabolism, this tablet inhibits tryptophan hydroxylase. So there's a less peripheral serotonin produced, and therefore it helps the carcinoid syndrome. It's used second line. Other medications can be used for the weird and wonderful gastronomas with the gastrin-secreting hyperacid nets, proton pump inhibitors to suppress acid. We've got some other drugs used in insulinomas, remember that there are other causes of gastrointestinal symptoms that also need to be looked at. Our oncologists would tend to use these other drugs, which aren't chemotherapy, but are molecular targeted therapy, such as sunitinib or everolimus, which can have side effects, but have some evidence in pancreatic NETs and also some lung NETs. Surgery can be considered various time points. So in pancreatic NETs, surgical treatment actually improves outcome, even sometimes when you've got distant metastases. But this can be debated. But generally, it is not like other cancers where if something has metastasized, it's not completely terminal. It means that there may be surgical options. And so therefore, it is important to discuss things in an MDT, especially with the small bowel NETs. Even if it's not completely curable, some of the small bowel NETs can produce this scarring and fibrosis, which means that they can be prone to small bowel obstruction and might need parenteral nutrition, dietary modification in the future, and will get recurrent problems such as bacterial overgrowth and weight loss. So it is important to make sure that patients have treatment, the appropriate treatment up front, and there is a surgical or the question of surgery is explored. Remember the somatostatin receptor and the somatostatin analog as an anti-tumor effect. Now, if you bundle that somatostatin analog with a radioactive material, which is a beta emitter like lutetium, you can deliver that lutetium or radiotherapy straight into, well, where the nets are, like a homing missile or magic bullet therapy. And this is a peptide receptor radionuclide therapy with Lutathera as the molecule that we have a license for in Europe. And you can see somatostatin receptors can be utilized for the imaging, as I said earlier on, the treatment with the cold somatostatin analogs, and then this hot somatostatin analog with isotopes attached. And there is good clinical trial evidence from a multi-centered world randomized controlled trial that Lutathera improves progression-free survival. Treatment decisions can be quite complicated, so you need an MDT, it depends on the clinical status, histology, where the primary is, whether the gallium PET or octreotide scan have uptake, what the burden, so how far the nets have gone, what the tumor status is in terms of functioning or non-functioning, and whether they've got carcinoid heart disease. And also we've got to think about some potential molecular markers which may be coming onto the scene and the cost effectiveness of these drugs. I'm not going to give you any references, but the ENET, European Net Society, produced standards of care and guidelines. They can be quite long, but they're quite comprehensive, and for specialists should be referred to from their website. Importantly, that we need to be aware that patients may have symptoms as a consequence of their NET or the surgery for the NET or the treatment, such as somatostatin analogs. They can have quite a lot of GI symptoms. So this is a prevalence of GI symptoms in a cohort in Wales who've been treated for a number of years for NETs. And there's some steatorrhea, it's quite a lot of steatorrhea, half of patients, and abdominal pain, gurgling. And these are things that you do need a gastroenterologist to look into, or some GI investigations management with a dietitian. And through some of the transformation that we've done in South Wales, with our networks of surgeons, gastroenterologists, we can actually improve diagnosis times by awareness, and hopefully those viewing this online or on a recording can become more aware about NETs in order to improve diagnosis times, as we have done in Wales, as well as patient experience. So I end my presentation there, and just a plug for this particular book by Adam Kay, which is bowel related and aimed at children, which has been out today. I thank you very much.
Thank you, Dr. Khan. Before we clock off and just seeing if there's any questions, there aren't any in the Q&A box, so now's your time to ask them if you have any.
So I think whilst wait and ask any silly questions if you want to, but there was a couple of questions I think that came through when people signed off. The word neuroendocrine is, in relation to these tumours, are is a slight misnomer. Is not related to the brain as such. It's just the fact that neuroendocrine cells have vesicles which secrete things and hormones into the interstitial space or a further cell, and they historically have sort of looked like, so that's where the neuro sort of type of cells come from. They're not from the brain, although they can form things in a neuroendocrine tissue in the pituitary, for example. So that the terminology can be quite confusing, and the old term was carcinoid, but we tend to call them neuroendocrine neoplasms, as I said, neuroendocrine tumors. So I'm just looking to see if there are any other questions. If we don't, there was one other question, I think, when people signed up, and that was around the use of markers, biomarkers in diagnosis, chromogranin A and 5-HIA. As I said, in diagnosis, they're not particularly helpful unless you've got someone clearly who's got florid carcinoid syndrome with flushing and diarrhea. And that's when you could get a 5-HIA. But as I said, imaging is the modality of choice to diagnose a NET, whether that's CT or MRI. And the take-home message is that if someone's got GI symptoms and they've had a normal colonoscopy, if they're over the age of 45, 50, don't just put it down to irritable bowel syndrome. There may be other diagnoses going on, one of which could be neuroendocrine tumours. So there's a question in the chat, a patient with hepatic metastatic NETs. Do we do debulk surgery? So that's a good question. There is a role. So as I said, for someone with let's take, for example, a small bowel, patient with a small bowel NET, maybe the case I used, there was a small bowel NET and some liver metastases. Obviously, we didn't go into detail in that case, but if that patient went on to have an MRI and it was deemed that the metastases were on one side of the liver, they were resectable with either a hemihepatectomy, and the small bowel primary was resectable together with some lymph nodes, one would undertake radical surgery. You wouldn't call it curative surgery because it metastasized, but you could resect everything that was visible. And people do have recurrence within a few years, but that does improve overall survival. Debulking surgery, as the question alludes to, is removing up to 90% of the visible tumor, usually in the liver. This is indicated if there is poor control of functioning symptoms. So carcinoid syndrome, if there was small bowel NET or lung NET which has been resected, the primary's been resected, and you're just left with liver metastases, one could debulk the liver metastases to reduce the number of cells, reduce the tissue that would release these hormones into the body and cause the carcinoid syndrome. So if a patient has on some metastatic analogues, you've tried a number of different treatments, then debulking surgery is often discussed but seldomly used in that setting. We do have other systemic treatments like radiotargeted therapy. There is some debate on whether debulking surgery in the liver improves overall survival as well, and that's debated. There's a number of conflicting retrospective studies there, including in pancreatic primary. Usually this would be a low grade or grade 2, but you wouldn't really do this in a high grade NET, which is more aggressive. Hopefully that answers that question. Let's see if there are any other questions. Otherwise, we may end it. Okay. Katie, if you're there, I think can you see any other questions? If there are no other questions.
No, there are no other questions, Dr. Khan.
Hopefully we can bring this to an end now. And it was a pleasure speaking to you. Feel free to contact me if there are any other questions at a later date.
Thank you, Dr. Khan.
Thank you very much, and see you soon.